to give the welcome speech.
Thank you, Dr. Vinita. One second, just start the YouTube once. Good evening, everyone. On behalf of IAP Kozhikode, firstly, I would like to appreciate as a Department of Pediatric Gastroenterology, Aster Calicut, for organizing such a wonderful CME. And I would go to my duties first. So I would like to welcome our dear President of IAP Kerala, Vijay Kumar sir. President Dr. Vijay Kumar sir has come out with this wonderful presidential action plan of promise, out of which the P stands for preventing non-alcoholic liver diseases. So so one by one, sir is completing all the presidential action plans. So next, I would like to welcome Dr. Mohandas Nair sir, our President of IAP Kozhikode. And I would like to welcome Dr. Ajit Kumar sir, a Professor and HOD Department of Pediatrics, Government Medical College, Kozhikode. I would like to welcome our dear Secretary of IAP Kerala, Dr. Johnny Sebastian sir. And nextly, I would like to welcome my beloved teacher, one of my favorite teachers, Dr. Ria sir, who is the Professor and HOD Department of Pediatrics, KMCT, and sir is a former Professor and HOD Department of Pediatrics, Government Medical College, Kozhikode. And our esteemed faculty for today's talk, I would like to welcome Dr. Seema Alam. Ma'am is the HOD Department of Hepatology, Institute of Liver and Hepatobiliary in New Delhi. And Dr. Marathi Satishagaran ma'am. Ma'am is I would like to welcome ma'am. Ma'am is a senior consultant and pediatric gastroenterologist in MGM Healthcare Rainbow Hospital, as well as in KKCTH. We would like to welcome you to virtually to Kozhikode ma'am. Next, I would like to welcome Dr. Suresh Kumar sir. Sir is the HOD Department of Pediatrics, Aster Calicut. And we have a lot of senior IAP members from all over Kerala. Dr. Purushothaman sir is there. Dr. Krishna Kumar sir. I would like to welcome each and every member who has come for the CME. And also welcome Dr. Vinita, who is a pediatric gastroenterologist in Aster Calicut. So I welcome all of you to the program and hope that we'll have a wonderful scientific session.
Thank you, Dr. Ajay. Welcome, everyone. Next, I would like to invite Dr. Vijay Kumar sir, our President of IAP Kerala, to give us the inaugural address.
Respected President IAP Kerala, Dr. Mohandas, respected Secretary Dr. Ajay, Dr. Johnny Sebastian, Secretary of IAP Kerala, and the backbone behind all the presidential action plan and all the other plans of IAP. And I'm very happy that all these programs are going very smooth. And I think this is the inaugural, the first program of non-alcoholic fatty liver disease. And Dr. Ajit Kumar, Professor and Head of the Department of Government Medical College, Calicut, respected Ria sir, my beloved teacher and former Professor and Head of the Department of Pediatrics, Calicut Medical College, and pediatric gastroenterologist, and now working at KMCT. And respected speakers, Dr. Seema Alam and Dr. Malathi Satyasekaran. Yesterday, I heard the program on IBD very early on. So it was a very informative talk. Yesterday, it was a nicely attended talk also. And monogenic IBD, all these things are very new words for me. And Dr. Vinita Vijayaraghavan, the chairperson, and senior faculty members like Parvati Madam, Krishna Kumar, Purushothaman sir. And as we have discussed, as a presidential action plan of 2022, we have included non-alcoholic fatty liver disease as a topic because there is obesity epidemic, and we know that children with obesity are increasing because in a tremendous pace, and we in endocrinology clinic are many of the cases are having type 2 diabetes, and previously type 2 diabetes was unheard of, and we were only dealing with type 1 diabetes. Now many cases of children are having type 2 diabetes, and in any specialty if you go, we can see a child with obesity with all complications. And in pediatric gastroenterology, non-alcoholic fatty liver disease is very common, and that is one problem, one disease that is producing cirrhosis and hepatocellular failure and all the other complications during adulthood. And hence the prevention is more important. So I'm very happy to note that the gastroenterology chapter has taken up this program of Presidential Action Plan Promise, prevention of non-alcoholic fatty liver disease in a great way. And this is the one of the first program of this Presidential Action Plan this year. And I officially inaugurate this program and wish the program all success. Jai Hind and Jai IAP. Thank you.
Thank you, sir. Thank you, sir, for the address. Our President, IAP Calicut, Dr. Mohandas, sir, is not able to join with us because he is traveling. I would like to, and Ajit Kumar, sir, is also not available for today because of he has such an internet connection. I would like to invite.
Mohandas, sir, is there anything?
No, sir messaged me right now.
Okay. Yeah.
Okay. So told me to, he's arranged because he's in the train, I think, he's traveling. Okay. I would like to invite Dr. Johnny Sebastian, sir, Secretary, IAP Kerala, to felicitate.
Yeah. Good evening, all. Respected Chair Mohandas Nair, sir, President of IAP Kozhikode, my leader and guide, the visionary leader behind the Presidential Action Plan Promise, Dr. Ajit Kumar, sir, my well-wisher in IAP, HOD and Professor at IMCH Calicut, Riya, sir, the former HOD at IMCH, a great teacher and the chairperson for the day, esteemed speakers of the day, Dr. Maldi Madam and Dr. Seema Madam, the person who is behind the whole show today, Dr. Vinitha Vijayaraghavan, pediatric gastroenterologist at MIMS, Calicut, the vibrant secretary of IAP Kozhikode, Dr. Ajay, other seniors and dear friends who have joined us today on this platform. At the outset, let me congratulate IAP Kozhikode as well as the gastroenterology department of Aster MIMS for taking up the prestigious Presidential Action Plan Promise in such a great manner and inaugurating it today. And I think that it needs a lot of awareness among pediatricians about the non-alcoholic liver fatty disorders. And today we have two great speakers to enlighten us in totality. And chairperson, the great teacher Riya sir, and as moderator we have Dr. Vinitha also. I wish this webinar all the very best. Thank you. Jai Hind, Jai IAP. Thank you.
Thank you, Johnny Sebastian, sir. Mohandas, sir, are you available? Is there range? Okay. I would like next. Okay. Okay. Next, I would like to invite Dr. Suresh Kumar Ike, our HOD of Pediatrics at Aster MIMS Calicut, to invite our esteemed chairperson, Dr. Riya sir.
Thank you, Dr. Vinitha. Actually, I think Dr. Riyas or beloved Riyas sir doesn't need an introduction to the participants of this meeting. Everyone knows Riyas sir well, and most of us are his students and or are his colleagues also there in this platform. Riyas sir was my teacher, mentor, my guide, and he actually helped me a lot during my initial days of practice. So I'm very thankful to him. So Riyas sir is a former HOD, Calicut Medical College. He's the first pediatric gastroenterologist in the whole government service. That's what I understand. So Riyas sir has authored a lot of books, published a lot of papers, and we are actually lucky to have him as our chairperson. If I continue to introduce, I think this time may not be enough. So he's actually beyond our time of introduction. So, sir, Riaz sir, I hand over you this platform. Please chair this session. Thank you very much.
Suresh, am I audible?
Yes, sir. Yes, sir. You're audible.
Yes, sir. Okay, sir.
Yes, sir.
Good evening, everybody. I would like to thank Team IAP Calicut and Dr. Vinitha for the privilege to chair this important session on non-alcoholic fatty liver disease in children. And thank you so much, Suresh, for the kind words about me. NAFLD, as you know, is one of the scourges of mankind, affecting millions of people all over the world. And it's one of the most common indications for liver transplantation in the world. Unfortunately, it's becoming rampant in children also, thanks to the metabolic syndrome. So early diagnosis and management are vital to prevent complications. And to discuss this intriguing issue, we have an exciting speaker in Professor CME, Head of the Department of Pediatric Hepatology of Institute of Liver and Biliary Sciences, Delhi. He has bagged several awards, including the prestigious Mehta Mitter Shankarnarayan Oration Award in 2018. He has more than 80 papers in national journals. He has published several books and also contributed chapters to several books in pediatric gastroenterology. And is one of the very few centers with DM pediatric gastroenterology course in our country. So it's over to Professor CME.
Thank you very much.
Madam, can you unmute yourself?
Thank you, Dr. Riaz. Am I allowed to speak?
Yes, ma'am.
Can I go ahead? Okay.
Yes,
Thank you, Dr. Riaz. I may have written a few chapters here and there, but it was you whose book I remember right from my time when I used to teach in Aligarh, and I used to refer that book to my students. So yours was a very, very first book that we had in pediatric gastroenterology. And I think it was a very great effort for the pediatrics people to get attracted towards pediatric gastroenterology. So thank you for that. Dr. Riaz, you've done your job greatly. Now do you want me to start the topic right now, Vinitha?
Yes, please, ma'am.
The screen?
Yes, yes.
Okay, so I'm doing the screen now. Yeah. Can everybody see my screen?
Yes, it is.
Yes, ma'am.
Yes, ma'am.
Can you? Yeah. Okay. So, yes. Yeah. So this is about pediatric NAFLD, just like Dr. Riaz was just talking about. It is definitely a very big problem. And as we go on with this lecture, I will keep on telling you the problems that we are facing because of NAFLD in our own setup and in the cohort that we're dealing with. So pediatric NAFLD and how to approach it. First of all, we must understand the definition of pediatric NAFLD. It is defined as fat in the liver of the patient, of the children, which is not secondary to genetic or metabolic disorders or infections or use of any steroidogenic medications or due to ethanol consumption or malnutrition. This is because of the I would say it's because of the overnutrition, largely overnutrition in our country, because we all remember the Kozhikode that we used to have during the malnutrition days. It was not insulin. There was no insulin resistance in that fatty liver. Now, this fatty liver, the NAFLD, is divided into two types. One is just NAFL, where there's fat accumulation in the liver, but without any inflammation and the liver enzymes are normal. Whereas the non-alcoholic steatohepatitis, that is called as NASH now, inflammation of the liver, and there is liver damage, as well as it can add on to the fat in your liver. And not only that, it can lead to cirrhosis and also HCC, that is hepatocellular carcinoma. So it's a very big problem. It's not just fat in the liver that is a problem. Now, that was the definition that was offered to us from the adult side, from the adult hepatology, as far as the NAFLD is concerned. But of late, recently, there has been a pediatric hepatology group who have said that, we have alternate etiologies. A simple NAFLD is somebody who has central adiposity, who has elevated the child has elevated BMI, more than 85th percentile, has evidence of insulin resistance, which can be seen in the form of acanthosis nigricans. He's usually a male child, or I think it's more likely to be male children, even in India. In the US, it was found to be more so in the non-Black and the Hispanics. In the Hispanics, it was more so seen in them. With a family history of NAFLD in the family, in the mother and the father and the grandparents, also diabetes in the family, and this family then, of course, has sedentary lifestyle. But they can be alternative etiologies, and they have to be really considered, especially if the child is less than 5 years of age. No risk factors for NAFLD, and of course, their clinical phenotypes and neonatal conjugated jaundice and organomegaly and psychomotor retardation, which can be present along with these things, with the fatty liver, which should take your mind towards a diagnosis. And I think Dr. Malti would do an excellent job with the mimics that she's talking about, and I would leave it at that. So what is the global pediatric NAFLD prevalence that we are aware about? We know that any child who is less than, who has doesn't have obesity, if you go into the population, you'll find NAFLD to be present in 9 to 10%, somewhere between 6, 7 to 10%. But if you see more robust children or with a high BMI, then it is more likely to go up to almost 40 to 50%. Largely, these studies have been done with the help of ultrasound, and the ultrasound, we know that when steatosis involves less than 30% of the hepatocytes, the ultrasound may not pick it up. So that is the limitation of the ultrasound in picking up NAFLD. As well as far as the prevalence in the subcontinent is concerned, we have few studies. There may have come some larger studies, but as of now, I don't think there are very many studies, from India, which have seen it in the population. And in the population is again 5 to 10%. But if you look up the more obese or children with metabolic syndrome, then you find them to be almost 40 to 60%. So like I told you, in 2 to 19 years of age group, prevalence of NAFLD is 9%. The NASH has a very small percentage, about 3%. This largely in the adolescents rather than in the children. When obesity cohort is considered, the prevalence can go up to 55 to 80%. NAFLD is strongly influenced by age, gender, ethnicity. As they say, like I told you, Hispanics, it was more common. In Asians, it is also supposedly more common. In the prepubertal phase, they can be as commonly seen in girls than in boys. As often, but in the post-pubertal state, they may be seen more often with boys. Although if you ask me, I do not have that much data to say that, but I think we see a lot more boys right now with NAFLD, or maybe that is the health-seeking behavior of our society, that we are seeing a lot of NAFLD in boys. What is the pathogenesis of NAFLD? The NAFLD has multiple hit theory, which is responsible for it. The intake of fructose and glucose and TGs, if you see the intake of these inside the intestine, which may damage the intestinal epithelium, and also the high caloric intake of the free fatty acids and bacterial overgrowth, all this together may cause fat deposition or fat uptake in the liver. This fat deposition is also happening because of insulin resistance, which may be because of the existing insulin resistance. Similarly, there are some genetics, especially PNPLA3. We have a paper on that also. Polymorphism, which is seen in the Indian population also, which is likely to be present in families who develop NAFLD. So in the background of genetics, with the insulin resistance, because of either, because of certain inflammatory processes going inside, or because of the deposition of the fat, this insulin resistance, this deposition of fat, and there could be new deposition of fat, which is called de novo lipogenesis, can result in NAFLD. So it's a multiple hit theory. You may have mitochondrial dysfunction, you may have oxidative stress, production of the reactive oxygen species, And of course, the the ER stress associated mechanisms are also involved in this. So hepatic insulin resistance is a disturbed suppression of the hepatic glucose production, but preserves stimulation of the lipogenesis. And adipose insulin resistance is insulin is unable to suppress the lipolysis, but whereas in the muscle, this insulin resistance causes the disturbed translocation of the GLUT4, which decreases the glucose uptake. So altogether, they are creating the whole milieu to cause de novo lipogenesis. Hepatocyte, the lipolysis of the adipose tissue is responsible in almost 59% of these cases to cause this free fatty acid to get deposited in the liver. 26% comes from de novo lipogenesis, which I was just talking about. And also from the dietary fat, 15% this is coming. So excessive load of the free fatty acid in the liver is the crucial cause of the liver steatosis. Why are we so worried about NAFLD? Why were we all talking about it right from the beginning? Because it's the most common cause of liver disease worldwide, both in adults as well as in children. It's associated with metabolic impairments such as, like I just talked about, insulin resistance, hypertension, abdominal obesity, increased risk of type 2 diabetes mellitus, metabolic syndrome, and even coronary artery disease. Even in young adolescent and also young adults. It can they can be evolution to cirrhosis and hepatocellular carcinoma, which can lead to the need for liver transplant. And it is mounting like an epidemic, epidemic phenomenon involving the youth of today. And I can see it in my setup that I have children who come to me with hepatitis A infection. Normally, a child who comes to you with hepatitis A infection, just 1% of them may go into liver failure. But if there are children who are obese and have NAFLD, if they get hepatitis A infection, they are more likely to land up into liver failure and land up into acute on chronic liver failure and lot of complications of cirrhosis. So what happens? How does it really happen? A baby who's born with a normal birth weight, who's born full term, what happens to him? What do we do to him to cause all these problems? Let me complete this cartoon to show you as to what are we really causing to this child. So this normal child is first of all formula fed, not given the breast milk, which is protective against NAFLD, and then he is fed on easy to chew things like Cokes, especially the beverages, the sugar containing beverages are the worst thing to give to children, and they're very much responsible for NAFLD. Lack of fiber food here and here, if you see right throughout, he gets this lack of fiber food. He has sedentary habits. He's playing what you call video games. He's watching TV, and of course then he has the associated vitamin deficiency. Vitamin D deficiency is very common with these patients, and a progressive weight gain, and with that he develops the NAFLD, or the fat in the liver. So this is how you see him. Like, his weight is going up from 90 to 97 percentile. His height is he's not reaching that percentile as this weight is reaching. His BMI again, so he's reaching high. His waist circumference is going high. This is the time when these are the cases where they're still going towards NAFLD or going towards obesity. We should try to pick them up. So we know that NAFLD is very, very associated with metabolic syndrome. 90% of the NAFLD have at least one feature of metabolics, and 33% can meet the complete diagnosis. Metabolic syndrome is a risk factor for NAFLD, as we have seen in other studies from Korea also. And we know that NAFLD is multifactorial. I told you that there can be a genetic component to it. There can be racial and ethnic component to it. And of course, even familial component to it, that children of NAFLD parents have a high risk of developing. We have also, published this one study on this. So a NAFLD with metabolic syndrome, as you can see here, we'll just show you as to what is the And of course, the family, if they have metabolic syndrome, the child is likely to take it up. This is acanthosis nigricans. If this is present on the creases of the child, you will find it a little discoloration, and this is suggestive of insulin resistance. No, this is one study which has shown that if you take up children who have biopsy-proven NAFLD and you take up children who do not have NAFLD, then the ones who had NAFLD, who had fatty liver, are likely to be, diabetic in 20 to 20.7% of those will have glucose intolerance or will at least be pre-diabetic or diabetic. Whereas those who did not have NAFLD, only 11% may be pre-diabetic only, none of them may develop diabetes. So this is the way this NAFLD can cause other metabolic diseases to come up. The rate of obesity that has increased it is coincided with the added sugar consumption in US. This was seen in US in that era where the added sugar consumption started increasing. That's a time when the obesity increased, and that's a time when the NAFLD increased as well. So the whole idea about greater consumption of simple sugars is causing this problem, and we are sitting on that volcano. We are also doing the same with our children, with the Coke and the Pepsi advertisements going all around. Even a child from slums who's not getting enough food to eat or not even being able to go to a school properly is getting a Coke to have. I mean, he has an access to Coca-Cola. So metabolic studies have proven that fructose was labeled as showing 2 to 3-fold greater association with plasma and liver triglycerides than observed with glucose. So it's simple sugars, and among them, it's the fructose, which is the most incriminating sugar. NAFLD can cause cardiovascular disorders, varied cardiac manifestations, atherosclerosis in 21%, hypertension in 21%, even in children. Left ventricular hypertrophy, it was seen that grade of liver steatosis correlated with the hypertension, even with the intimal thickening, and so atherosclerosis. Children with NAFLD and hypertension had higher BMI and as compared to those without hypertension. What another risk factor, if you have a mother, you have a young adolescent as obese, she becomes a mother later on, she has gestational obesity, she has gestational diabetes, she has high fat diet during the pregnancy, and with some postnatal factors like they won't give her the baby high obesity and high dietary fructose and all this consumption carries on later on in the baby. Adolescent insulin resistance develops, and this is the child who will then likely to go in for ectopic hepatic fat deposition in these newborns is very, very often seen because the immature fetal adipocytes, which cannot handle excess lipid crossing the placenta during the pregnancy. And with this, all this happening during postnatal period, these are the children who are going to land up into NAFLD. So the natural history of the diseases, the first the child develops NAFLD, that is fatty liver. He remains stable for some time, and then he develops a small proportion of these children will then develop inflammation and have NASH, which will further give rise to increased steatosis, which further give rise to inflammation, which further again give rise to steatosis. So it becomes a vicious cycle. And these are the patients who have this inflammation again and again in them will then go in to have cirrhosis. So fatty liver, NASH, and cirrhosis. This is what is the whole story about the NAFLD. And we are kind of staying somewhere here. From fatty liver to NASH, we are beginning to see very soon we will have cases who will come to us with cirrhosis also. I haven't seen maybe one or two cases I've seen of cirrhosis, but this was not entirely because of the feeding. It was also some hormonal disturbances in the child. So cirrhosis is less often seen in our age group, but NASH is very often picked up by us. So who should be screened for NAFLD? All of these children and overweight children with risk factors like central adiposity, insulin resistance, pre-diabetes or diabetes, dyslipidemia, sleep apnea, or family history of NAFLD and NASH. We are doing this with all our children who have family history of NAFLD and obesity. We take them up for NAFLD. Consider the screening of siblings and parents of children with NAFLD if they have known risk factors for NAFLD, like I just told you, obesity, some ethnicity, insulin resistance, and diabetes, pre-diabetes, and dyslipidemia. So the screening test can be ALT. You can even do ultrasound, but ultrasound is not a recommended screening test. Why? Because it doesn't pick up until the steatosis goes above 30%. ALT is again not a good screening test, because if you just have steatosis, you may not have raised ALT. So raised ALT will only happen once a little bit of inflammation or the steatosis has gone beyond a certain point. So any elevated ALT more than twice upper limit should be evaluated for NAFLD and for other causes of chronic hepatitis as well, which Dr. Malti will take up with you shortly. So whom should we be investigating for NAFLD? Less than 3 years, abnormal LFT, obesity, investigate. 3 to 10 years, abnormal LFT, obesity, investigate. More than 10 years, abnormal LFT, normal weight, investigate. And more than 10 years, abnormal LFT and obesity, investigate. So who have we left out? Hardly anybody. Almost all will be investigated. So any child who is having obesity with abnormal liver functions, and I would say not even abnormal liver functions, you must try to look up for fatty liver in all these patients. And of course, we put them on to weight reduction and proper diet for another 3 to 6 months and reevaluate them. So the follow-up screening for NAFLD should be initial screening. If it is normal, even then you should repeat the ALT after 3 years if the risk factors remain unchanged. Consider repeating the screening even sooner if the clinical risk factors increase. If the child has gained more weight, then take him up again. If he's developed IR, that is insulin resistance, take him up again. Sleep apnea, again take him up. So the diagnosis is a diagnosis of exclusion. Liver biopsy should be considered for those who have the assessment of NAFLD in children who have increased risk of NASH, or who have advanced fibrosis, or who have taken some drugs which may have caused fibrosis. Transient elastography, or the fibroscan that we do, has been validated in children. MRE, still we don't have very many studies which have validated. So because these two modalities are non-invasive, we should look at them for the progression of fibrosis from baseline to over a period of time. Does every child need a biopsy? Maybe not, but diagnostic uncertainty in some of these patients may be helped if you do a liver biopsy. The other diseases may also be picked up on that liver biopsy. High risk of advanced disease you will get to know if you have a child with liver biopsy, with the NAFLD. Persistently raised transaminases, if they are there, then these continue despite lifestyle interventions, you should do a biopsy. Even in morbid obesities, you should do a liver biopsy. So what do we look for on the liver biopsy? We look for periportal fibrosis, like you can see here. We look for steatosis, like you can see here, ballooning degeneration, and lobular inflammation, which then shows you that this child may be having NAFLD. So how to prevent this? An overweight, obese child can go on to develop he can become an adult NAFLD, and this OR for increasing BMI is almost as much as 2.49 to 2.7. I mean, 2.5 times to 3 times fold increase chances of him becoming adult NAFLD is there if he is an obese and an overweight child. ALT elevation can also happen with a OR of 1.5 times even if he is having normal weight. So we must try to look after NAFLD even in children, to early prevention and lifelong treatment of overweight and obesity to reduce the risk of adverse liver outcomes in adulthood is what is the need of the hour, even in India. These are some modifiable risk factors for NAFLD. Some of them are non-modifiable risk factors. So obesity, waist circumference, sedentary lifestyle, high intake of sugar-sweetened beverages, obstructive sleep apnea, not breastfed. These are modifiable, which can be easily looked after. Whereas these are others like low birth weight, PNPLA, which is a genetic defect, parental obesity, which has already happened, family history of NAFLD and type 2 diabetes, ethnicity of Hispanic, and a male are more likely to develop NAFLD. So what are the principles of treatment of once a child has had fatty liver? You decrease the sedentary behavior, increase the physical activity, modify his diet, and there are some drugs still available which may help. So the consumption, the guidelines for the diet should be that the consumption of at least 5 servings of fruits and vegetables per day. Tell them to have salads, tell them to have fruits, not fruit juices, because fruits come with a lot of fiber, and fiber helps as an antioxidant. Minimization or elimination of sugar-sweetened beverages. Limits of 2 hours of screen time should be for the children so that they can go out and play, they can have some kind of activity. I have found that if we ask the parents to involve the child in some kind of a playground activity, which is the best. It's not the gym which helps the child. Even bicycling on the roads is a little dangerous in India, at least, with so many people around. So what is best is to make them join an academy, make them have small groups which can start playing in their playground close to their home. And that is the best way to bring the child's weight down. No television viewing for children below 2 years of age. 1 hour of physical activity is a must. Family matters, they should eat breakfast together, limit the meals from outside the home, eating family meals at least 5 to 6 times per week. Allow the child to self-regulate his or her meals. Make him take decision about his life. He has to be told what is happening to his liver. Avoid overly restrictive pattern and adequate sleep. Type of physical activity, almost any form will help. Be it resistance, be it vigorous, be it sustained exercise, be it dancing, be it aerobic training, and maybe cardio-metabolic risk factors will come down with this. Healthy eating, aerobics, and resistance training in youth has helped. It's been seen in so many studies. So the target weight loss has been decided by adults. In adults, it's not been seen in children. We don't have targets in children, but if you can lose 3 to 5% of the body weight, then it appears to improve steatosis. But if you can lose up to 10%, this may be needed if you have necroinflammation, if you have NASH, if the child has developed NASH or adolescent has developed NASH, then he should lose up to 10% of his total weight to improve this necroinflammation. So among the diets, the carbohydrates, if their fructose is given, it causes de novo lipogenesis. Gluconeogenesis causes reactive oxygen species, the insulin resistance. But if you give fibers, it decreases DNL, it decreases the insulin resistance, increase short chain fatty acids also increase here. Lipids, if you give in general, if they increase, they cause increase in the de novo lipogenesis and hepatic uptake of free fatty acids. Whereas if you give short chain fatty acids, then a decreased appetite may help the child. Inflammation will decrease, de novo lipogenesis will decrease, and there will be increased lipolysis. Minerals also like copper and iron have been found to cause problems here. Whereas the vitamins it's the vitamin E which has been found to be the best antioxidant among, and also C. Traffic light concept is there for the food that the child should take. Green, low calorie food can be eaten as much as possible. Yellow for moderate calorie foods, it should be occasionally taken. And this is the red for a high calorie food that should be rarely taken. And this is what it is. So common foods which can be freely taken are fruits, vegetables, lean meat, fish, eggs, nuts, beans and lentils and whole grain breads and cereals and rice and pasta, reduced fat dairy products, and water and milk. Whereas common foods which should be taken, should go easy on them and should be occasionally taken, are processed meat with reduced fat and salt, refined processed bread and cereals, full fat dairy products, reduced fat and sugar cakes, and reduced fat flavored milk or fruit juice with no added sugars. But deep fried foods, processed potato dishes, processed meat, with high fat content, especially beverages of simple sugars, should not be taken, and you should avoid these things from your diet. Same has been said by the National Institute of Nutrition, says slow and steady reduction in body weight, eat small meals regularly at frequent intervals, cut down sugar, salt, fatty foods, refined foods, and soft drinks, eats complex carbohydrates and low glycemic foods, limit the fat intake, shift from saturated to unsaturated fat, and low fat milk consumption. There is one, as far as the pharmacology is concerned, what can help, one landmark trial that is known as a tonic trial, where they gave the vitamin E or metformin or placebo to these children, and they found that in between the three groups, the only place where there was some improvement seen was in those who had high ALT, and there was some improvement even on histology seen, but not all children showed that improvement. So vitamin E might not be helpful in all patients, but yes, in those who have high ALT or are bordering on NASH can be helped with vitamin E, and that is what we do. There are so many other drugs like metformin, omega-3 fatty acids, docosahexaenoic acid, pre and probiotics. These have, some studies have been done here and there, but we don't especially have very many studies to actually show their evidence or confirmed role in the management of NAFLD. There's one more treatment modality, that is bariatric surgery, rarely performed for children, but specific indications are when the BMI is very high, 40, or if it is BMI is between 35 to 40, but with other significant diseases like diabetes and high blood pressure, then you can do these bariatric surgeries to bring down these BMI and help out these diseases. All other appropriate non-surgical measures have failed to achieve, then you can go for the bariatric surgery, and they're generally, if the patient is generally fit for anesthesia surgery. There's one more thing that people are seeing, but there are no studies in children, and that's why I've not included a slide here, is putting in a balloon inside the stomach and decreasing the capacity of the stomach and decreasing and causing early satiety in the child may sometimes help, just like the bariatric surgery. The summary of this talk of mine is decrease the sedentary behavior, improve the physical activity, modify the diet, and vitamin E has some role, especially so if you have biopsy-proven NASH. Rest, vitamin E should only be used in patients who have increased ALT, not in all patients. Thank you. Hello.
Yes, hello.
Yeah.
Thank you, madam, for the great talk. I mean, it is, you have touched up all the points regarding NAFLD, pediatric fatty liver disease, and it's in a very concise, extensive, but very concise manner. Ria, sir, could you, are you available, sir, there, or shall I ask the questions in the chat box?
Have I gone beyond my time period? Because I thought I was going in time.
Yes, ma'am. It's just 3 minutes more. That's all, ma'am. It was in time, ma'am, actually. Or should we ask the questions at the end and go ahead for the next talk? Will that be okay, ma'am?
I'm okay. I'm okay with anything. So let me just.
Yes, I can unmute now. I made you co-host now.
Okay. Thank you so much, Seema, for the excellent talk with such beautiful slides. So shall we go to the next talk? Vinita?
Yes, please. We'll go to the next talk and then have the questions at the last.
So there are several diseases which masquerade as NAFLD, and these are called the NAFLD mimics. Examples include Wilson's disease, lipodystrophy, Korsakoff, etc. Unfortunately, some of the commonly used drugs like cetirizine and valproate can also cause disease mimicking NAFLD. So it's very important to identify these children to give the correct treatment promptly. To discuss NAFLD mimics, we have another stalwart from Chennai, Dr. Manadi Sathishagaran, whom I know personally very well for the past 30 years. She's an excellent clinician and an awesome teacher. She is presently working as senior consultant of pediatric gastroenterology in Rainbow Hospital, Chennai. Professor Malathi has bagged several awards right from her MBBS days. She was the president of ISGAN from 2018 to 2020. She has more than 75 publications in various national and international journals and has contributed 23 chapters to various textbooks in pediatrics as well as in pediatric gastroenterology. So over to Professor Malathi for a talk.
Evening. Thank you, Dr. Riaz, for that wonderful introduction. Thank you, Dr. Vinita. It's such a joy to be once again in this platform to speak to you. I was there yesterday. Thank you, Dr. Vijay Kumar, for remembering my talk. And now Dr. CME has given a very nice introduction platform for this topic of fatty liver disease. She's outlined it so well, and she's left that mimics to me so that I can take it over. So both of us together are going to teach and share our views about fatty liver disease in children, how it is so much different from the adult or the fatty liver disease which we see in adults, but more or less that one group will take you to the same end. They'll go for cirrhosis and hepatocellular carcinoma. So as Seema was saying, Dr. Riaz will also remember till 1980, we did not have any confusion. Pediatricians just diagnosed per se. We did not diagnose one fatty liver disease as an entity. NAFLD was first described, as Seema was saying, only in 1983. And by that time, everywhere obesity started increasing, including India. Ultrasound was available everywhere, and adult hepatologists were introducing this topic of NAFLD. And we also, the pediatric hepatologists, started seeing cases of obesity, ultrasound showing fatty liver, and then we also put saying pediatric NAFLD. So pediatric NAFLD, by that time, a definition was given. Chronic hepatic cirrhosis, and as Dr. Seema says, children 18 years or younger, which is not. The most important word in that definition is not secondary to ethanol. Most children will not take. 18 years is very, very rare. Only nowadays we're seeing a few. Not related to genetic, not related to infection, not related to steroid medications. So pediatricians somehow didn't like this diagnosis. This is a diagnosis by exclusion. We don't want that. We are not talking about that. Why have a NAFLD then? So this was the thing, and this was the classic the diagnosis, what we used to see. This thing I've got permission both from the child also. This was the typical. He was very happy, no problem for him, happily eating, like she said, over nutrition. His grandmother used to cook very well, and every time this boy would go correct to the grandmother's house 3 times a day, and she loved to feed him. No jaundice, no vomiting, nothing wrong. He loved TV, he loved watching, no games, nothing. He'll smile at me also. He will say, no problem, there's little pain, and that's all. That was his problem. But when we started investigating him, we found, yes, he has acanthosis nigricans, which is a marker of insulin resistance. He had his liver and spleen. His SGOT, SGPT was high. It was on the higher side. And then you found that serum insulin was and grade 2 fatty liver. So he had dyslipidemia, he had this acanthosis nigricans, and this we started calling NAFLD. I remember a paper even from ILPS where I was the judge, and we gave that award. So many papers came, pediatric NAFLD. Though we did not like the term, we were using the term pediatric NAFLD. The only reason being, we had to have a universal language. Everyone had to talk the same talk. If I speak something else and they speak something else, it will be different. So we were also calling NAFLD, though we did not want that term at all for children. So but what's in a name? What is wrong if we call it pediatric fatty liver disease or NAFLD? But then everyone gets confused. So what happened was a nice paper came in 2018, which Dr. Seema has also represented, that all the pediatric fatty liver disease, all is not NAFLD. And here they emphasized that in children, especially the younger children, as Dr. Riaz was saying, a group of disorders which have fatty liver, we don't call them fatty liver disease. They are due to metabolic liver disease. They have fatty liver. They will get washed out, or they will be just into this trash bin of NASH and NAFLD, and we will forget about them. So we do not want this word NAFLD. For pediatrics, we would prefer to call pediatric fatty liver disease, because after all, we don't have alcohol, non-alcohol. So all of them are non-alcohol only. But we don't want this term. So they kept on writing about this. We would like to have our own description. We will call it pediatric fatty liver disease. And this was the paper in 2018. And so, we felt, but then we had to call it NAFLD, we had to call it NASH, because that was the description given everywhere. Saga continues, terminologies. Adult hepatologists also slowly, they did not like this. It's after all, a negative thing. There's no, it's not a positive diagnosis, it's a negative diagnosis. So they said in 2020, as Dr. Seema said, they said, we will call it MAFLD. Just one alphabet got. NAFLD became MAFLD. So what is MAFLD? As she said, it is a metabolic dysfunction associated fatty liver disease. This is more positive diagnosis. An individual should have steatosis, but they will have metabolic functions like either pre-diabetic state, they will have waist circumference increase, they may have dyslipidemia, and that is be MAFLD. I will tell you about pediatric MAFLD. Pediatric hepatologists continue to call it pediatric fatty liver disease, but by 2021, a paper came where in King's Hospital, they analyzed all the fatty liver disease. Why this confusion? What is the percentage of children who will have this MAFLD, which is now, NAFLD is now become MAFLD? How many of them will have that? How many will them have metabolic liver disease? How many where will not find the diagnosis? So out of 441 children with hepatic steatosis, type 1 or those with majority metabolic liver disease was 40%, and those with MAFLD or the earlier term NAFLD was 51%, and the unexplained was 38%. This was the paper in February 2021, but by October, it became very clear. Now, the proposed classification of pediatric fatty liver disease is 3 types. Type 1, or that IMD, which said, because as Dr. Ria said, even drugs can cause fatty liver disease, and we have infections causing fatty liver disease, and therefore fatty liver disease with an identifiable systemic disorder, such as a single gene defect, drugs, or even celiac disease, or viral hepatitis, or as he mentioned, Wilson disease, will be called type 1, where you know it is metabolic specific disorders causing that. Type 2 is fatty liver associated with metabolic dysfunction. So the term MAFLD has now come even for pediatric. And type 3 is at this time, during the time of assessment, underlying defect is not being able to be identified, but it may become apparent with time. So I hope now you are very clear. Pediatric fatty liver disease, type 1, where it's an identifiable disorder. Type 2 is that MAFLD, which was earlier called NAFLD. And third one, type 3, is at present no underlying defect. So pediatric MAFLD, already the slide has been shown. So what should you have for pediatric MAFLD? You should have steatosis. Steatosis either by histology or by imaging or a blood biomarker. So far, we do not have a blood biomarker, but if some sensitive test comes for pediatrics, that will be the one. It should show steatosis. Along with steatosis, this is called metabolic associated fatty liver disease. Don't mix it up with metabolic diseases of the metabolic liver disease with fatty liver. That's different. I will tell you about that. This is metabolic associated fatty liver disease. So metabolic disorders, it's metabolic dysfunction associated fatty liver disease. There should be a metabolic dysfunction. One of the 3 criteria should be there. One is excess adiposity, presence of pre-diabetes, or evidence of metabolic dysregulation. You can go into this definition again, already given by Seema. This metabolic regulation will include your hypertension, all age-related. So it's now becoming more a positive diagnosis. If you have that, if you have this waist circumference according to age and sex, all that is drawn out. And so you must have steatosis plus one of these 3 criteria. But now we are not going to talk about all this because I'm going to talk only about the mimics. So how does a fatty liver disease, how do we diagnose fatty liver disease in children? Mainly is only by imaging and histopathology. You may consider fatty liver disease when you have asymptomatic elevated transaminases. You may consider in the presentation, but on examination or in the manifestation, you are not going to tell someone here, this is a fatty liver. And how can we say that? Because it's a pathological diagnosis. But you can say, suppose the liver is smooth, suppose it is a rounded border, it is there. So the presentation may be different. It can present just as elevated transaminases, but the main two ways where a fatty liver word is used is only on imaging and histopathology. The genetic studies tells us the etiology. So the types of hepatic steatosis we see in are the macrovesicular steatosis, where you see this large cells, the ballooned out hepatocyte filled with fat, and the nucleus is pushed to the periphery. I always used to say, when someone comes to your room and they don't belong to that class, they will try to push everyone. So it's like that. They are not supposed to be there. Fat is not supposed to be there. So it will push everything to the periphery. Whereas glycogen is part of it, so the nucleus stays in the center. But you can also have microvesicular steatosis. Why am I trying to teach you so much of pathology? This is because fatty liver in children, the mimics, many of them are microvesicular steatosis, whereas MAFLD, or the topic which we are discussing, where you said it is obesity, overnutrition, where weight reduction is going to bring it down, is a macrovesicular steatosis. Very, very important. This is very, very important. So pediatric NASH, which we called it earlier, is a macrosteatosis, which has already been described. So the fatty liver terminology, first when I heard was in 1976, when I was doing my DCH and CMC Vello in Welcome Block. They showed me this sort of this child. You know, this child also looks obese. He's got nice cheeks. He's also got nice cheeks, but this child looks sick. And then it was a fatty liver, and they said, "What is this?" And you know, you all know, even in 1959, fatty liver in children, as Seema was saying, kwashiorkor. That's all we knew. Fatty liver in children, what is the cause? You go and look Ria's book also, it will be only kwashi as the first. And then we had all those features, and they say, what are all the features of kwashiorkor? We had to rattle it from top to bottom, from mosaic pattern till everything, and fatty liver. We had to say, because this fatty liver was not because of the increased thing, it was more. Now recently it has been found it's because of paroxysmal and mitochondrial dysfunction because of the malnutrition. So the cause of fat deposition can be, mostly it is a mitochondrial injury in most of the metabolic disorders. It can be due to some problem with the beta oxidation. It can be due to some problem because of the increased cholesterol. The cause of the fat may be very different. So now you know the, as mentioned earlier, so there are several causes of pediatric hepatic steatosis. The most important, the dark blues, are the ones which present in infants and children. That is all the metabolic disorders. I will show you this metabolic disorders according to their presentation. The black boxes are those which are seen in adults. So you get this, so the viral infections, especially hepatitis, and then you get it in all the medications, especially valproic acid as mentioned, corticosteroids also, uncontrolled diabetes you can get. And then I told you about this bariatric surgery. After that, you can get a rapid surgical weight loss. And again, you can get a fatty liver because of that, alcohol abuse. But all the many metabolic liver diseases can have fatty liver, but we don't call it fatty liver. We call them by their name. We say Wilson disease, but on histopathology, you may see fat, but that doesn't make them a fatty liver disease. We just say inborn errors of metabolism presenting with fatty liver. So what is the hepatic manifestations of hepatic steatosis? What are the manifestations? They can present as acute liver failure. They can present as neonatal cholestasis, very important. They can present with organomegaly, either hepatomegaly or hepatosplenomegaly. They can present with some developmental delay or psychomotor reduction or even growth delay, or they can be just elevated transaminases asymptomatic. And you will find the ultrasound showing fatty liver, or they may show liver biopsy, may show some amount of fat. So these are the presentations of hepatic steatosis. So the presentation is varied, as I was telling you. So let us look at each one very quickly. In acute liver failure, because many pediatricians are here, the most important causes of acute liver failure are where it is a fatty liver is one of the manifestations. Mitochondrial hepatopathy, you get a microsteatosis. You know how mitochondrial hepatopathy presents. They have both hepatic and neuro manifestations. and they have failure to thrive, they have lactic acidosis. Why is this important here? Why is it important? Is because you don't advise liver transplantation for this group. You have to do the genetic studies. Maybe one rare type may be given, but majority you cannot use. Fatty acid oxidation defects are another one, very similar to GSD. It will come like hypoglycemia, but they are more sick, they're acidotic, lactate. It's microsteatosis. Urea cycle disorders also, I've been showing you a picture. Hereditary fructose intolerance, galactosemia, and Walcott-Allison syndrome. A nice paper has been written by Dr. Seema's group on the metabolic liver diseases presenting as acute liver failure. This is a classic presentation of a child with urea cycle disorder where you will have microvesicular steatosis. Recently, we had this child, look at this, high ammonia from 303, then it dipped down, then went up to 273. We had to start treatment. This child did not require dialysis, but we managed with your Edison sodium benzoate. Ammonia came down. SUT-SGPT was very striking. Prothrombin time was prolonged. And urine GCMS showed an increased uracil and orotic acid. But it was surprising because this was a girl child, but still we were thinking, and this was finally ornithine transcarbamylase deficiency in X-linked. So this is a child who will require transplant soon. Now this child is better. This was when it entered the hospital. Then once the ammonia came down, it became better. In this child, ultrasound, the liver is hepatomegaly is there, and they have fatty liver. So if the ultrasoundologist will say, I'm seeing hyperechoic areas, they may say it is a fatty liver. So this is what I was talking about, urea cycle defect. The others are galactosemia. You may see as acute liver failure that can also present with fatty liver. You know how we pick it up either by cataract and then vomiting. Mitochondrial hepatopathy, I've already told you. Tyrosinemia, how do you pick up those children? They become very sick soon. They have high alpha fetoprotein. They have persistently elevated INR. You find that INR is not correctable. Urine succinyl acetone is positive, and these are the children who present. So why should we know? Fatty liver is common. The problem is because of the disease per se. So the treatment changes. So the treatment changes, and you cannot confuse this group with the group Seema was talking about. These require specific treatment like NTPC, all liver transplant for tyrosinemia, galactosemia, lifelong lactose-free diet, mitochondrial hepatopathy. Liver transplant may not work. That is, we should be very clear about it and not push a transplant for these children. Walcott-Allison syndrome, I had seen one child with recurrent hepatitis and diabetes, and these children also have fatty liver. And here, it is difficult to manage this child, but control of the diabetes mellitus and management is what we do for this. The second presentation, as I was telling you, is the neonatal cholestasis. This is a very important presentation. It can be tyrosinemia, I have told you. In neonatal cholestasis, the injury may not be pure mitochondrial. In acute liver failure, somehow most of them are microvesicular steatosis. But in the neonatal cholestasis syndrome, you can have macro and micro. Niemann-Pick disease, I will show you a case of that. Cystic fibrosis will be showing citrin deficiency, inborn error of bile acid synthesis, not transport. The synthesis might show some fatty liver where you have low GTP and low bile acids. These are the common causes of fatty liver in neonatal cholestasis syndrome. So this is a tyrosinemia classic where you have the free fluid ascites quickly appearing in a child, high alpha fetoprotein, do the urine succinyl acetone quickly. And if you start NTBC early, I think Dr. Seema will give you her experience, they can even defer a transplant. So here the stools are yellow. I just want to show you that. This is not biliary atresia. It is an intrahepatic cholestasis. And this was at which thank Dr. Naresh and Jagdish for sharing the slide, a tyrosinemia child going in for a transplant. Look at that. If you do not find and just say it's a fatty liver, yes, they do have fat. But you know, the cause, it is a different cause. It is tyrosinemia. There's a metabolic disorder, and this child underwent a transplant. So this is a cause. This is a Niemann-Pick. Will also look like a fatty liver, though actually you see the cholesterol crystals, hepatosplenomegaly, and you see the classical foamy, large cell with foamy cytoplasm. You see the cherry red spot on fundus examination. You all know, actually, though it is put in as a lipid storage disorder, it is a defect in intracellular trapping of cholesterol, and now we know it's a positive Philippine staining in cultured fibroblasts. What to do? No effective treatment. Some have tried stem cell transplant. Some have given this replacement therapy of Pegustat. So here also you get a fatty liver. So NP disease, you see these fatty cells, and you can also see these cells, which are the storage cells, and these are the glycogen cells. So on casual looking, they look like steatosis, a macrosteatosis only. Citrin deficiency, a spotter. So Niemann-Pick, urea cycle disorders, all these pediatricians will just make a spotter diagnosis. They are not going to talk about as MAFLD here. Citrin deficiency, this classic cheek, chubby cheeks, very much like GST, but the child is so sick. It's got hyperammonemia, it's got hypoglycemia, it's got hypoalbuminemia. Why is this child so sick? Then you realize it's a citrin deficiency, and they present with cholestasis. Classical, you do the genetic studies, and here the treatment is only high protein and low carb diet. Some of them may survive a little later on also, but we lost this child. Cystic fibrosis, I think Seema will remember this paper. They had put it as a CPC in 2013. That same month, a child was referred to me with cholestasis, failure to thrive, liver biopsy showing macrovesicular steatosis, more than 90%, same type of thing. So immediately I made a diagnosis of CM, even without the gene thinking. So someone asked me, how did you make? So I said, no, I just read Seema's paper. So I remembered that because, it's so rare. Cystic fibrosis presenting as neonatal cholestasis and a liver biopsy. Here it will be classical. It will look so much. If you just show this, you will think, oh, this is MAFLD, because you have so much of hepatocytes showing things. I think you should remember this paper, and it was a beautiful CPC they had published. The third presentation is like organomegaly. We all know which is that organomegaly presentation, which will appear like a fatty liver. It will be GSD. So GSD, we all know it's the most common. It is because of abnormal glycogen or normal glycogens in the liver and other organs, and more than 13 types of GSD are there. And now, earlier when we used to take a class, we'll only say know about 1, know about 3, and we'll give some differences. But we've now proved all wrong. Those children who are living, when we are doing the genetic studies, we are getting reports of GSD6, GSD9. So it's not as common as that. So this was the classical. You see the cells with glycogen, you also see the steatosis. And we used to say, if you see this, it is more 1 and not 3. But now we are not able to say all that. Only genetic studies can clarify it. And this is the past positive. So whenever they see fat, we always say it must be GSD. This is the classic presentation. Whenever you see a healthy child, always eating. When you can see Riya's book also, always eating. 1 biscuit here, 1 biscuit there. This will be one classic feature, one abdominal distension, hepatomegaly. So this child also on liver biopsy may show fat, but that doesn't mean it is going to be MAFLD. So this is the classical 9, and these are the pictures. The fourth presentation is with some delay in motor or psychomotor retardation. And in this, it's a growth delay, celiac disease. Why do they have fatty liver? Because of the malnutrition. You can have it in lipodystrophy, fatty liver you can have. But most important I want to talk about is this LALD deficiency. In infants, it can present as Wolman disease. All of us make it spot diagnosis. You see the X-ray, you see this calcification, adrenal calcification, you make a diagnosis. We lose these children. Well, the liver biopsy may show some amount of cells looking like fat cells, hepatosteatosis, but actually it is not that. We may see these storage cells in between. But what is interesting now is LALD presenting later in life presents very much like NASH. And they say NASH, which does not respond, or MAFLD, which does not respond to weight reduction, do this even in older people. Do LAL gene mutation and you may pick it up. And this was, this thing I think is an eye-opener for us. And here you can give recombinant therapy. This is what I was talking about in adults. The last one presentation is just asymptomatic child with elevated aminotransferases. Clear, Dr. Yas said, Wilson disease. Wilson disease, fatty liver. Yes, some amount of steatosis will be seen in fact in Wilson disease. And why did we stress that? Because till then, all our copper liver disease were ICC. In ICC, we kept on saying no fatty liver. And so when Wilson disease, we started seeing fatty liver, this helped us to differentiate. But you know the triad, you will have a low celluloplasmin, increased copper, Kf ring. You will not introduce Wilson disease as fatty liver disease. You will only say on histopathology, we saw fatty liver because the treatment is different. Viral hepatitis, especially C and sometimes in B, medications, especially tetracycline valproate, it's microvesicular. In recovery from sepsis, it's also microvesicular. In Wilson disease, it may be macro and microvesicular. Autoimmune hepatitis also sometimes you can get steatosis. So this is the thing, asymptomatic transaminases, you will see some amount of fatty degeneration, but the copper content, copper staining will show it to you. So there are a lot of red flag signs which will tell you, see, this is not the one which we are talking about, the common garden, 50% of fatty liver disease seen in obesity, seen in that. This is completely different. And I would like to just sum it up by saying, the age, most important is the age. What have I been showing you all this while? The classic range of our NAFLD. NAFLD does not occur in children less than 3 years of age. This message, if we are able to give it to the pediatricians, I think it will be very good. It is infrequent in children less than 10 years of age. So age. When the infant is less than 3 years, when the child is less than 3 years, don't make a diagnosis of NAFLD first. It may be that it may coexist, but it is not. Exclude all the metabolic disorders. Less than 10 years, it is infrequent. It does not occur, it is infrequent. Next, it is a classical age. It is more than 10 years. Everything is fitting into that, but it is unresponsive to weight loss. Then also think something more. It is something more. Third one is early onset fatty liver disease. Presence of acute liver failure. They don't present with acute liver failure like I was telling you. Mitochondrial hepatopathy, your tyrosinemia, your urea cell defects, cholestasis. They don't present to you with cholestasis as a manifestation. They don't present with large organomegaly like the ones I was showing you about. GST, big liver, large liver, or other liver diseases rather than pediatric NAFLD in a strict sense. In a strict sense, you have to think about these three. Think about the age. What is the age of this child? Before I make a diagnosis of NAFLD, age, less than 3, no. Less than 10, maybe, but I will think about something else. Weight reduction done, still not improving. And other manifestations, like I told you, especially liver failure, cholestasis, developmental delay, growth retardation, all that, don't think of NAFLD as the first diagnosis. So this was the classical acanthosis nigricans, striking in children with obesity, which will be for NAFLD. This was the last one. I was just trying to tell you, it's still a sort of a confusion. This 11-year-old boy who came last week to me, this was his photo when he was taken, when he was young. So that time also he seemed to have a cheek, but he was perfectly well. You know, this GSD presentation, only we have to be always careful. Why did I not think of NAFLD in this case? This boy is coming with bilirubin of 9. He's facing like acute on chronic liver failure. His SGOT, SGPT were more than 600, 700. He had minimal free fluid. He had dyslipidemia. He had CK, which was high. Creatine kinase was high. His Wilson disease workup was negative. Autoimmune workup was negative. Then this big liver, so we said, okay, it's still the same DNA we had put. It is probably Wilson disease, probably it is hereditary fructose, it's the same thing. And then when we did this, we got this report. Look at this, more than 90% macrosteatosis. But when you look at this, maybe you will say, oh, this is MAPL. No, this child has increased CK. This child has ACLF as presentation. There is some metabolic disease which has been missed. So we are now waiting for the genetic studies. So I would like to conclude showing this algorithm. Suppose you have a child, obesity, like Dr. Seema was saying, increased transaminases, or it shows something on the ultrasound. They said fatty liver. Suppose you have all the three, just go and look at the age. If it is less than 3 years, NAFLD is very rare. If it is 3 to 10 years, it is rare. If it's more than 10 years, it is likely. So if in less than 3 and 3 to 10, work up for all the metabolic, look at for all the features. As pediatricians, we are good at spotters. And if you read certain books, you can just pick it up. Like I told you, citrin deficiency, urea cycle defects, you know that. You'll pick it up. So don't get confused with this big thing of NAFLD. We have a set of disorders which we have to do, work up for that. But suppose it is more than 10 years, then you will do what? You will do all this lifestyle diet, exercise, and all what Dr. Seema was telling about the amount of fruits, vegetables, but work up for the metabolic syndrome components, because MAFLD is what? Metabolic dysfunction associated liver disease. So you must work up for the diabetes, you must work up for insulin resistance, you must look at the waist circumference, you must look at the hypertension, dyslipidemia, all that you have to do. See what parameters they have and help the child out. After that, if it is pure MAFLD, if they don't respond to weight reduction, no, you have to work them up more again for some metabolic disease. Anyway, by this time, you would have asked for questions regarding medication and viral hepatitis and all that would have been done. Suppose they respond to weight reduction, then only it is MAFLD. So I hope this is very clear. The age is very, very important. And then look at this, and now MAFLD will be the word which we'll all be talking about, MAFLD, and in that you have steatohepatitis when the enzymes are elevated and there's inflammation. So in conclusions, I would just like to say fatty liver, when you say, it is just a histological pattern. It is a different pattern of histological, all the different patterns we have, cirrhotic pattern, steatic pattern. So there's a histological pattern in that macro and micro. Pediatric fatty liver disease is a spectrum. It includes 3 groups. The first one, which we said, it will include IEM, the medication, the hepatitis, and then the others. Then you have the MAFLD, which is the second group, and then you have the unidentified. In children less than 3 years of age, fatty liver is a presentation mostly of metabolic liver disease. So please identify them, because the treatment is so specific for each one. Everything is so specific. It's not like just weight reduction in this. They may be obese. Most of the GSDs are nice and round, but there you try to give them uncooked cornstarch. You have to be very specific in their diet for that. Otherwise, we'll have more issues. Liver biopsy is the gold standard in diagnosis of fatty liver and its etiology, and genetic studies should be done in all children with fatty liver disease suspected to be due to IEM. I think we don't shy away from liver biopsies, unlike adults. Adults don't do so much of liver biopsies. In children, liver biopsy is the gold standard, both for diagnosis of fatty liver and also to find out things. Remember, MAFLD and other metabolic liver disease may coexist. Don't mix metabolic liver disease and MAFLD. MAFLD, again, I repeat, is metabolic dysfunction associated fatty liver disease. So it's a dysfunction which we are talking about. And thank you for the patient listening.
Thank you so much, Dr. Malati, for this truly awesome talk, which has really been an eye-opener for all of us. I also agree that it's high time we change the terminology of NAFLD in children. Now it's open to the floor. Any questions?
There are some questions in the chat box.
Yeah.
Would you like?
Which is better, Dr. Malati, which is better, GGT or ALT for diagnosis of NASH?
So if you ask me, did you say GGT?
GGT, yeah.
No, for NASH or for NAFLD, I think it is best to do the ALT, which is actually the enzyme to show you necroinflammation. So that is what is better than doing, see. And somebody's asked about FibroScan as a screening tool. Nivnita had asked this. Sunita, FibroScan has come up as a good screening tool. There is a parameter called CAP in that, CAP score, which is called as the attenuation parameter, controlled attenuation parameter. So CAP, we have at least reported in children that any CAP above 260, in fact, the median value that we got for children to diagnose steatosis in them was about 285 or something. So CAP, FibroScan can be used. In the FibroScan, it's the CAP which tells you about steatosis, whereas the rigidity or the KPS score that you have tells you about the fibrosis. There was one more question after that, which talked about difference in etiology for micro and macro steatosis. I think this Dr. Malati has addressed so well that you should now be thorough in this. Dr. Malati wants to take up this question, she can.
Yeah, I think this thought, we just put everything together. And that's, I think, as you start looking at it, it is so well defined even earlier. We were talking when we used to ask, what are the causes of micro? We used to say tetracycline, but we didn't realize that metabolic liver diseases, many of them have microvesicular steatosis. And that is a very thing, and we are putting everything together as fatty liver disease. So that is very important when the diagnosis comes. And when you have a slide like that, which I showed you last, it's macro. You can even now, you will think, oh, is this GST or is it going to be hereditary fructose? Though, you know, those bigger things. So pathology, I think as hepatologists, pathology is so important, and liver biopsy should be done in these children. So the microvesicular injury, more when it's a mitochondrial injury, I think you will agree with that. And as she said, ALT is now used to Dr. Riaz. Actually, they've given the thing, even they have said when it's more than a cutoff of 26 and 22, twice upper limit of normal, that you take it for screening for NAFLD.
So there is one more question by Somashekar, who was asking about vitamin E therapy and what is the duration. Somashekar, and since you also asked about the potential adverse effects, the study that I was quoting, tonic study, it was also done in adults, and they later reported the authors themselves, Dr. Arun Sanyal, reported that there was a little more mortality in that group who received vitamin E, especially in adults. So that's why the authors became a little skeptical about adding vitamin E to patients with NAFLD, and that is what is being followed in USA as of now. As far as metformin is concerned, till the last time I have reviewed the data about 3 or 4 months back, there was no head-to-head studies with positive results for metformin. So there is no reason to give metformin. You may give, but there has been no benefit seen. As far as the carnitine, somebody's asked about carnitine. Can I give with vitamin E? Carnitine has never been studied. As far as I know, there's no study to quote about carnitine. So carnitine as such has not been seen in this particular group of patients.
Duration of vitamin E, madam. Duration. How long would you give it?
So, Shekhar, I would rather give vitamin E. Like I would try to talk about the adverse effects first to make you alert about the fact that we should not give it for very long. So as soon as the ALT improves, and I have made sure that the child has also gone down on his weight and the lifestyle modification has happened, I usually take them off from the
even for adults, so much like 3 months they've advised, because they had reported a lot of prostatic malignancy in that group. So 3 months they said, and they said like just like that, 3 months if they are not responding, like Dr. Seema was saying, they don't respond. So that is the best way, to watch them. So even I don't write for more than that, but this is the only drug which we have. Unless they are in the pre-diabetic state, then I tell the parent, metformin, no, but one study is there, I'll give you, but I'll call you back. I don't write it for 3 months, 6 months, and then send, because I think we need more work. And all the work is now to come from SEMA only. ILBS will give us the data. Then we'll press it.
As far as carnitine is concerned, there is no study. Somebody talked about brown sugar. I didn't understand what does this really mean. Brown sugar and up and north, it has a bad connotation, so I'm not really commenting.
No, this is the other brown sugar, which is the natural thing.
Okay,
so
are you talking about the cane sugar?
Sugar is sugar.
Jaggery. Is it jaggery?
Little bit like the jaggery.
Somewhat similar.
I don't think there is much difference
which you are thinking about.
I don't think there is much difference between these simple sugars. So it is the same as the normal sugar.
Best thing to give them complex starch, that helps them, because the chewable count increases. That's the only way. Fiber and fruit as such.
What about fructose?
So fructose is the worst thing. There is head-to-head trial of glucose versus fructose, and they have found that children with fructose have more of de novo lipogenesis in the liver than those with the glucose. So the worst thing is fructose, and that is why all my NAFLD children, I tell the parents there should be no juice in your fridge. There should be
what
no
about
juice
honey
coming in the groceries.
Honey contains a lot of fructose, so is it dangerous?
Yeah, I think this whole idea, I don't know if you've read that paper, I'm sure Dr. Malti would be aware of that paper. There's, I think, a hepatology paper where they have started saying that please redo the diet that you give to your infants. Do not give juices anymore. Stop giving juices. Similarly, I think in India, we should write this paper that stop giving honey to our babies. Although honey is not given that much of quantity to our babies, but even then, I think this is time that we realize even honey is not good.
Thank you, madam. Both talks were really nice. Excellent talks.
Tima, what about fructose of fresh fruits?
I just mentioned during my talk itself, I tell the parents, buy fruits, give them fruits. The reason, the difference between the two is that you give juice, you don't give the fiber, and the fiber fights with the de novo lipogenesis. So to decrease the lipogenesis, you need fiber, not the sugar. So give fruits. It has a lot of fiber, even if it has fructose in it, even then, but there is fiber, and that is an antioxidant. And I think that compensates for the fructose. So it's best for the child to have fruits rather than fruit juice.
Is there any role for UTCA, ursodeoxycholic acid?
No. No cholerytics.
NASH.
Only in the cholestasis we give, otherwise no.
And there was one thing that I wanted to mention. I want to say, Dr. Malati, you were very right about the fact that the adults, they call something called as lean NASH, where the child is, where the patient is thin, and like you said, they don't respond to the lifestyle interventions. This lean NASH has been found to be, lot of those have been found to be because of LALD deficiency.
Yeah, that's the one I was
talking about. Yeah,
LALD deficiency. So that's the group which they want us
so
to.
it's not just in children that we can be having this confusion. It can even be in older. And your child that you're talking about, the 10-year-old ACLF, I think the amount of steatosis you see in the liver, I mean, LALD should be looked for, especially with dyslipidemia also present.
Yeah, I was asking, I spoke to the pathologist. LALD, he says he sees more microvesicular, and he definitely sees those bifringent crystals in that. I was thinking, I spoke to him.
CK is high, no, ma'am. That is again.
CK is also was high. That is why we were still thinking, and I told him most likely it will come back as one of the GSTs. I'll send it to you. I think I'll put it up. I'll send it to Vinita so that, you know, I was very surprised when I saw that liver biopsy, everything. And I was thinking, why I'm going to talk about it and I'm getting one slide like that. So I told him, give it to me. I'm going to show it today. Just day before, hot. It's fresh.
So this may not be the actual NAFLD, but if you ask me, this is the situation that we are facing in our wards right now, that you have a child obese, comes to you with simple HAV and lands up in ACLF.
Yeah, I think that is also, that's why it's telling, but we've done all the markers for autoimmune by viral markers. So I was also thinking whether it's NAFLD with super added some drug or medication or, you know, thing. But, you know, he says in this type of CK elevation, this type of jaundice, ma'am, I don't think so. Anyway, let us get the genetic report.
Yeah.
Riya, sir.
So shall we wind up the program?
Yeah.
So we have had two excellent talks on this vexing problem by two authorities in this field, Professor CME and Professor Marathi. And I'm sure these have demystified this challenging problem to a great extent. Before winding up this program, I would like to congratulate both speakers for their excellent performance. Thank you so much.
Thank you. Thank you. Thank you, Dr. Riaz. Thank you, Vinita.
Thank you, everybody.
Thank you. Very nice.
Ma'am, can I give an official? Thank you. Okay. Thank you both Malti madam and Seema madam for your valuable time and expertise on this topic.
Dr. Vinita, I'm Dr. Pushpa. Just one suggestion to experts in the field, because in the last few years, Ayush is given too much of importance, and Ayush give more importance to this honey and all during this even younger infancy. So in the coming years, we pediatricians and the pediatric gastroenterologists should be highlighting the damage which is likely to be caused to this entity. And of course, we should be taking some measures to screening test for this entity among the school kids. So I was thinking how it should be done. I was having the impression that ultrasonogram annually once after screening of the BMI, which can be done by the school teachers itself, and the selected group, we could have done ultrasonology. But it's not that sensitive. I knew now. So what about the fibroscan? Is it portable? How costly it is? Whether IAP and the PTA group of the higher economically higher level schools, whether we can implement the as a pilot program to begin with. I don't know anything about the fibroscan. Is it anything portable like that or institutional?
Okay, if you want me to answer, then yes, fibroscan is quite easily portable and can be utilized. We in fact have ambulance in our hospital right now, which goes to most of the areas and mohalla clinics of Delhi, and it is fitted with a fibroscan. So we do fibroscan in the mohalla clinics of Delhi government. As far as ultrasound is concerned, I do not think that we should put the ultrasound in the trash bin completely. I still feel that ultrasound has a lot to offer. And especially if you're wanting to do a school health program, ultrasound may be helpful in helping you especially so when you are dealing with children who are obese and having a higher BMI. There, ultrasound works very well.
In the department, we were discussing on the screening program in schools for pediatric fatty liver disease and the end organ damage also with the part. So what we talked to the radiologist, it was that ultrasound machine cannot leave the hospital. So the patients will be there is some rule regarding that. Either the patients
there are portable ultrasounds available.
Yes, but portable also, we had talked about that, but then they said that there are some rules regarding, taking the machine out. That is what I've been informed. So the next option was the fibroscan. That is what I had asked the question, whether, we can correlate.
Portable, but of course, portable fibroscan is going to cost you a lot more. And a portable ultrasound is going to cost you hardly 20 lakhs rupees maybe. And a portable fibroscan will be in crores. So it's a different kind of a ball game that you're dealing with.
Yes, ma'am. Yes. Thank
you. I had just a comment, Vinita. Can I give this as Dr. Neelamon?
Yes, ma'am. I was going to call you, ma'am. I just saw your message. You're online. Thank you, ma'am.
I wanted to congratulate Malati and Seema for that awesome deliberation. Just two comments. One is the last one, which you talked about, portable. The company actually had offered to give it on rent for studies. So they actually have a portable, and I think it was less than 1 crore. I think they quoted 50-60 lakh, but they were happy to give it for a day on rent. So in case you have any plan, that was one suggestion. Second thing is, we also did a large study on fibroscan and children. And then we were able to compare it 45 liver biopsies with the fibroscan, because we take liver biopsy as gold standard. And in ours, it was 248, 240, close to that. And there are large studies in children. I think they also say 240, 45, most of the large study, except one said 210. So I was a bit surprised when Seema quoted 280, because even I remember the paper from your center, Seema. Rajiv, if I'm not mistaken,
Vikrant has done that paper, and we have found higher amounts in much higher than, and see 240, 250 is a little difficult for me to believe, because even when the fibroscan manufacturers quote that this 230 to 250 can be normal. So
that's why I'm saying that we did a biopsy proven. So that is very difficult. But out of 300-400, we had 50 biopsy proven, or 48, something like that, biopsy proven. And in that, it came as 245. Of course, I mean, that's a very small study. But I was just thought I'll share that this was a biopsy proven study with fibroscan. And maybe there's more to it. So I thought I'll just share that. Thank you, Vinita, for this opportunity.
Thank you, ma'am. Thank you, ma'am, for your suggestions. Thank you, Malati madam. Thank you, Seema madam. Thank you, Neela Mohan madam. And on behalf of IAP Calicut, I would like to thank everyone who has been present on this webinar and making it a success, and with very valuable suggestions given by the stalwarts. Thank you, Ria sir, for chairing this 2 sessions. You're always you have done it very smoothly, and I'm very honored, sir, for you to be part of this webinar. I would also like to thank Vijay Kumar sir for the Presidential Action Plan promise. Because of that only we have a path to create such awareness among our fraternity. It will benefit our children. Thank you, Dr. Johnny Sebastian sir, for being part of this program. Thank you, Mohandas sir. Even though you are traveling, you are also attending the program. Thank you, Purushottam sir, for talking about the honey part in the Ayush program, and we'll make sure we put that in the history also. Thank you, Suresh Kumar sir. Thank you, and special thanks to Prashant sir, who is a pediatric gastroenterologist at SAT Trivandrum, for guiding me through this. And thank you, very big thank you to Dr. Ajay for being our ever vibrant secretary. And thank you to the senior IAP members and friends for making this webinar a success. Thank you, everyone. Good night.
Thank you, ma'am. Thank you, sir.